Welcome to InCast. Enjoy Health Education's podcast for dedicated healthcare professionals, educators, and administrators who are passionate about making a difference, encouraging healthy outcomes, and finding innovative ways to engage and empower new families and staff. Here's your host, Debbie Young. She's been a childbirth educator and doula for almost 30 years and came to Enjoy based on her love for educating families.
Whether it's a long-awaited or an unexpected pregnancy, women who are over 35 years of age may have a different experience than their younger sisters. The older term, geriatric pregnancy, has been replaced with advanced maternal age, which signals to the parents and providers that additional care will be taken to improve outcomes. Navigating pregnancy over the age of 35 can be empowering and positive with the right care team and support system in place. Parents in this category often bring emotional maturity, stability, and a strong desire to actively participate in their care. However, they may also face heightened risk and some social biases. In today's podcast, we'll discuss how to foster the best outcomes and find a provider who genuinely cares. Our guest today is Lexi Hill, a well-known maternal fetal medicine doctor who works with both parents and professionals to make sure mothers get the best care on their journey to birth, no matter what their age. She says, "Through my years in the medical field, it's clear that something is missing between the patient-physician relationship that needs mending, and a key component to this is empowering patients to advocate for themselves. My goal is to help improve self-advocacy for physicians as well as patients for whom they provide care. Ultimately, I want to leave a lasting positive impact on the lives of my clients who will do the same for their families, friends, and/or patients." Thanks for joining us again today. We're kind of doing a part 2 with Dr. Lexi. Last time we talked about unexpected changes to using an MFM during your pregnancy, and she gave a lot of great information. Today, we're going to be talking about creating the best outcomes in advanced maternal age pregnancy, which we kind of alluded to in the last podcast. You might want to give that a listen. Thanks so much for being with us again, Dr. Lexi.
Yeah, thank you for having me.
Yeah, it's great to have this conversation out in the open because I think people are sort of afraid of the ideas. And I know that sometimes people can get a stigma around being over 35 or sometimes over 40 and having children. But the truth of it is, through all of time, people have been having children later than we think is necessary. So let's talk about that today.
Awesome. Let's do it. And I always like to, everyone, when we get the definition of advanced maternal age, and I always love putting in air quotes because of the other terms that we'll talk about, but it's 35 or older at the time of your estimated due date. So when we have patients, they get referred in sometimes for advanced maternal age, like, but I'm 34. Yes, but your birthday is going to happen before your estimated due date, which is when you're 40 weeks pregnant. Therefore, it squeaks you in as the advanced maternal age.
Yeah, but it's kind of like I was 34 when I got pregnant. Is something going to switch in my body and when I turn 35?
Right. And that's like all the confusing data behind it too. It's like, what is so special about 35, right? Like, why is it that that's the number? And there's actually data that kind of shows there's a continuum, if you will, from 35 to 39. And then when you hit 40 and beyond, the risks increase even more.
Mm-hmm. I'm sure if there's other things going on in the mom's life, having that extra care with you might be really important at 35. So we'll talk about that more.
Yeah.
How many patients do you see in a practice? I mean, you just have let's say yours is a typical practice. How many patients are coming to see you because they have advanced maternal age?
Ooh, it depends on the location. I would say certain parts of the United States, certain cities have higher rates of advanced maternal age. So across the board, if I were to guess off the top of my head in the percent that I see their advanced maternal age in the last year or two, I would say percentile wise, I feel, and again, remember I'm high risk pregnancy, so I'm not just the OBGYN, right? I see I'm skewed a little bit for my percentages. I would probably say 20 to 30%.
Okay. So 20 to 30% of your patients fall into the category. You just said something that made me think, do all women over the age of 35 need to have MFM following them, or do some OBs feel like unless something goes on, we're going to be okay?
That's such a good question. And my professional opinion on this, from reading all the articles and being up to date from the recommendations from the American College of OBGYN and the Society for Maternal Fetal Medicine, the big thing is that anatomy ultrasound. So there are certain things that someone of advanced maternal age needs to have done. They can do those through an OB office or through an MFM office. Either one is fine as long as they get done, right? And so Down syndrome screening is one of them that should be offered. Doesn't have to be done, but should be offered. And the anatomy ultrasound is huge too. Those are the two big non-debatable things in my professional opinion from the data that we have, and anybody can follow them. And certain places can do anatomy ultrasounds. Now, that anatomy ultrasound should be a detailed anatomy ultrasound. It shouldn't be a standard. And so, this is a great question for a person who's advanced maternal age to ask their OB provider, who does my anatomy ultrasound? And if the answer is the OB group does it, is it a detailed anatomy ultrasound, and who's reading it? Because one of the things that we don't know, and my friends who are my age in our mid 40s don't know who's reading their scans. And it is a disservice if the person reading an ultrasound for the fetus that needs a detailed anatomy ultrasound, such as someone that's advanced maternal age, is not trained in reading fetal ultrasound. And I will say, going through OBGYN training, we aren't really trained as OBGYNs to truly read a detailed anatomy ultrasound. That's not in the standard wheelhouse of an OBGYN resident. Now, for an MFM trained fellow, totally in the wheelhouse. So if the OBGYN says, yeah, we're doing your anatomy ultrasound here, that's a big red flag to me. As if I were the patient and as a provider in this subspecialty niche area, that's a big red flag for me. Yeah.
Okay, so if the OB says, I'm going to make that happen, could they then have someone like you read it? Or is that a connection that the OBs have with MFMs?
Every community is different. Some OB groups have MFMs inside their practices that read scans for people who need the higher risk scans or the detailed anatomy ultrasounds. Some OBs refer patients to an MFM office solely for ultrasound so that they can get the ultrasounds. Some OBs have physicians within their practices or hospital groups that are radiologists that are reading and performing these fetal detailed anatomy ultrasounds. It depends on who the OBGYN group and or their hospital or whomever owns their practice is contracted with. And that's, again, it varies not just from state to state, but city to city and then hospital system to hospital system. So I mean, you could live in Phoenix, Scottsdale, and Glendale, which are all in the area of Phoenix metropolitan, and it could be done different ways. Isn't that crazy?
It is. But the fact is, you want somebody who knows how to read these specialized ultrasounds to read yours if you're advanced maternal age.
Correct. And there's kind of like the main things other than those two of the Down syndrome screening and that anatomy scan. There's a couple other things in there that are really need to be done. A growth in the third trimester at minimum. You don't have to do them all the time necessarily. And again, it's a continuum. If you're 47 versus 37, that may depend, right? So this is kind of a blanket-ish statement, but it doesn't cover everybody. But at minimum, the Down syndrome screening being offered, the anatomy ultrasound at 20 weeks, a growth ultrasound around 32 weeks, sometime in the third trimester, and then some type of fetal monitoring near the very end of the pregnancy. That is of a ton of debate. There is not a specific gestational age that must start. But because we know that stillbirth risk is higher, it has to start at some point in time, in my professional opinion, from review of the data. Now, if you're that person that was 34 and you turned 35 like a day before, on the continuum, you're at the lowest end. So, like, sure, I get that, right? Yeah.
All right. And that's a conversation your provider will probably have an idea of what they would like. And then you can have a conversation about all of that. Right.
Correct.
Okay.
Yeah.
So you had mentioned Down syndrome. What
Mhm.
are other common conditions that may crop up specifically for advanced maternal age patients?
Yeah, if we stay, and this is exactly how I talk to my patients about it. When we talk about risks, we talk about maternal risks and fetal risks. And I'm always like, well, that's what I do, maternal fetal. So we'll do that. So from a maternal standpoint, hypertension, not just general hypertension, but preeclampsia, which can develop in a pregnancy and is not just high blood pressure, but you can get symptoms associated with it. Bad headaches, visual changes, changes with your labs like your liver functions, your platelet function, your kidney function. And if you develop preeclampsia, lifelong risk of hypertension increases and lifelong risk of cardiovascular disease increases. So that is number one thing for moms. Number two, gestational diabetes being diagnosed will increase. And then thing number three, I lump it all together: preterm labor, preterm contractions, preterm birth, and cesarean. So not a lot we can do for that, but just counseling to let them know that that is going to be an increased risk for them. So that's the maternal side. And then the fetal side, number one, like you mentioned, and we were talking about chromosomal risks, not just Down syndrome. So that's trisomy 21. Trisomy 18 is considered higher in those that are above the age, at and beyond the age of 35. So chromosomal risks in general. Second one is going to be growth restriction for the fetus. Third is going to be risk of stillbirth. And those can be counseled for patients. I kind of group them if you're 35 to 39 versus 40 and above, because the risks will increase for all those things I mentioned if it's 40 and beyond.
Well, that's good to know. I mean, it's the problem is that the mom might be like, I'm so healthy, but
Yeah.
her having a healthy body isn't necessarily meaning that those things can totally be avoided. So they just need to be looked for.
Yeah. And it's one of those things where we all know as we age, our risk of things increase: high blood pressure, diabetes, stroke, general things. Our bodies are older. So I like to tell people it's nothing you're doing wrong. Just our vessels are older. So if you think about a placenta and a uterus trying to stick together for, almost a year, right? If our vessels aren't as good, it's the small vessel level. So it's things that you might not even think about or notice, but implantation may not be as good. And those are the things. The highest risk person in this advanced maternal age category is someone 40 or older, and it's their first pregnancy.
Okay.
Stillbirth risk for those people increases even more. And so not even all 40-year-olds are created equal. And this is, like you said, too, minus other comorbidities of coming into a pregnancy with lupus or diabetes or hypothyroidism or anemia. We're just talking just age, right? And these are the risks associated. Yeah.
Okay. Well, that makes me wonder about the trends of, you said a 40-year-old woman who's having her first pregnancy is at more risk for stillbirth and maybe some other things.
Mhm.
Do you see in your own practice, and I know this is going to be different for every practice, but are people coming with advanced maternal age who are having that first baby? Or is this maybe a blended family, or just mom has five and this is the sixth one and she's over 40 now?
Yeah, it's kind of a mix, in all honesty. I will say that the first time above the age of 40, I've seen more of, just anecdotally from my practice. And I think it's various reasons, maybe delaying having children a little bit more, maybe not wanting to start a family until later too. So various things. I've seen both of them. I would say majority are probably multiparous, meaning having had prior children, but still seeing a good handful of those where it is their true first pregnancy. Yeah. And we have to also kind of throw the curveball in there of, it is harder to get pregnant the older we are, right? Our eggs, we don't have as many of them, and the ones we have are not as good. And that's just part of the nature of aging for women. And So we will see miscarriages increase some in individuals above the age of 35 and particularly above 40. So that brings in this curveball of use of reproductive technologies like IVF. And that takes everything I mentioned to you, and those risk factors or those risks are actually there with IVF too. So you kind of increase them even more if you're advanced maternal age with in vitro fertilization use.
So even if a mom wasn't advanced maternal age, but she was using IVF to become pregnant, would that mom be using you probably also?
Yes. And with IVF, I always still break it down mom and baby risks that we have. And for mom, preeclampsia is going to be there just from the use of IVF, as well as increased risk of cesarean. And that can go hand in hand with implantation of the placenta, because sometimes with IVF, it could be a lower implanted placenta, and that could lead to placental issues like placenta previa or a low lying placenta. So that's kind of from the mom side. From the fetal side, and this is what a lot of patients don't realize. So when they see me after IVF, they're like, well, no one really shared this with me before I went through IVF. I'm like, well, that's we do preconception consultations too. So next time, but for the fetus after IVF, the number one thing I talk to people about are structural abnormalities, because birth defects, the baseline birth defect risk for just any pregnancy is somewhere between like 3 to 5%. So after IVF, the risk of certain birth defects can increase slightly. The ones that carry more water, abdominal wall defects, where the skin doesn't close over here, maybe even some midline facial defects of the face, like clefting, as well as heart defects. And heart defects are the most common type of birth defects anyway. So it is so important after IVF, that big detailed anatomy ultrasound, again, detailed with a person who knows how to read it. And I advocate always for advanced maternal age or IVF, having a first trimester ultrasound, because you can pick up a lot on a first trimester ultrasound. You can also do early ultrasound screening for Down syndrome, looking at the thickness of the back of the neck, presence or absence of a nasal bone. So early ultrasound is super helpful. And thankfully, after IVF, they want to make sure the dating looks good, the fetus is still there after the implantation, and all these things. And so most people will have that scan too. So for IVF for the fetus, number one, structural abnormalities. So much so, we don't only recommend the first try ultrasound and the anatomy ultrasound at 20 weeks because of the fact that structural defects, the most common being heart defects, echocardiograms are recommended. We usually do those around 22 to 24 weeks. So structural things is number one. Number two is growth restriction. And so we do recommend at least that one growth ultrasound in the third trimester. And if you have other comorbidities or risks, we may do more. So that's why when someone's advanced maternal age and IVF, you got two hits against you in a way for those risks. And so you may get more than just that growth ultrasound at 32 weeks. And then the third thing, so we've got structural abnormalities, we've got growth restriction, and then we've got stillbirth risk. ACOG added, believe it was between 3 and 5 years ago, maybe, a recommendation of antenatal testing or antenatal fetal surveillance starting at 36 weeks for those who have undergone IVF. The gestational age at which to start fetal monitoring or antenatal testing for someone of advanced maternal age, not as clear cut. But for IVF, and again, remember, because the age can be on such a continuum there, but for IVF use, given the risk of stillbirth being associated, they recommend starting antenatal testing around 36 weeks.
And would that be coming into the office for an ultrasound or fetal monitoring? What does that look like?
Antenatal fetal surveillance, it's so funny because I wish we had a universal term we used. I feel like ACOG is using very regularly antenatal fetal surveillance. You may hear antenatal testing, antenatal monitoring, fetal well-being checks, all kinds of things like that. Antepartum testing, sometimes they call it. It can be various forms. A non-stress test, where they put the two belts around you. The top one looks at the uterine contractions. The bottom one, they find the baby's heart rate and look for certain things on this strip of a monitor of continuous fetal monitoring. And it's continuous because it's usually 20 to 30 minutes roughly. So it's not continuous like forever. And that's one option. You also have the option of an ultrasound where they look for practice breathing, movements, tone of the muscles, and the amniotic fluid level. They call that a sonographic biophysical profile. Now, for providers listening, like, well, a biophysical profile includes a non-stress test, which is the one with the belts. True story. So you have many ways to skin that cat. You can also do what we call a modified biophysical profile, which takes the non-stress test, which is the two belts, and then checks the fluid. You can do this once a week. You can alternate it. It depends on how you want to do this. It also depends on how high the stillbirth risk is for that individual person. So if you're someone who is 40 years of age, let's say, not associated with IVF, and it is your first pregnancy, stillbirth risk beyond 37 weeks is about 1 in 100, 1 in 116 specifically. If you are 40 years of age, but it's not your first pregnancy, you're looking at a stillbirth risk that's more about 1 in 300. So when you talk to your provider, it may be like hey, if your first pregnancy above the age of 40, we're going to do twice weekly testing because that stillbirth risk is higher. So stillbirth risk is never zero. So a low risk pregnancy with no true concerning comorbidities or high risk issues, that stillbirth risk is quoted at about 7 per 1,000. And then an advanced maternal age person ranges from 11 to 21 per 1,000. So we have a beautiful chart in little articles we have, and I keep it by my office desk in case someone's like, well, what is my risk? The problem becomes very few people have just one risk factor. It's usually multiple. So it's very difficult to know how to quote it. But if they have multiple, we can definitely say it's higher than just having one. And that gives you more fuel to explain why you're doing what you're doing for the testing. And because the testing is so confusing, I did do an entire YouTube video on this, and it's fascinating. I found it very educational for myself, but my friends who are OBGYNs, they send their patients to it a lot because it's very confusing to be like, why am I doing this? And so there's a handout that goes with that video that's exactly what you and I have been talking about of advocacy. And it says, here are the questions to ask your provider. Do I need antenatal testing? And then why? Where am I going for it? Do I go to my OB office? Am I going to the hospital? Some people go to the hospital to do the monitoring. Some go to a radiology location in a hospital or an office setting. Some go to an MFM office. It just depends. Am I doing non-stress tests or biophysical profiles or a mix of the two? How frequently? So a lot of questions to ask and advocate for yourself to understand why you're having it done, where you need to go and how frequently, because it can be very, very frustrating to get those scheduled because they're frequent. Once to twice a week is a lot to ask of anybody.
It is. Can I put the YouTube link on the show notes for?
Yeah.
Okay.
Yeah. I'll send it to you. There's a YouTube for the antenatal testing. What is fetal well-being testing? And then I have an advocacy assistant specifically for advanced maternal age and a full module, a course for advanced maternal age. And if you want, I can just put a free link to it. So if people want to take the course of advanced maternal age, then they can get the free download within it too. And it goes through kind of what we'll talk about today, but a little more in detail, I would say. And it also includes a lot of information, questions for a person to go through the module and check and see what they learned, and also a full handout on how to take those questions to their provider. There's 5 modules I have like that: hypertension, diabetes, hypothyroidism, advanced maternal age, and IVF. So we'll put those in if you want to.
Our listeners would love to get a hold of that.
Yeah.
And most of them are not parents, but they are professionals. They're educators, doulas, midwives,
Yeah.
whatever.
Yeah.
So that would be excellent. So one of the things you said earlier was sometimes they come to you after they're pregnant, but you mentioned that you also offer preconception visits. Can you tell me more about that?
Yeah. We always, 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 as MFNs, love it if someone's had a preconception consultation. Main points and goals of that: number one is to really understand the risks that you have in a future pregnancy. So then you can decide, are you accepting of those risks? Do you want to go through a pregnancy knowing those risks? So for advanced maternal age, the consult goes almost just like what we talked about, exactly what the risks are and how we would manage those in a pregnancy. And then making sure that when someone becomes pregnant, if they are of advanced maternal age, that they have a checklist, or really make sure that all those things are done dependent upon where they live and who their OB provider is. And a lot of preconception visits are, as I mentioned, deciding whether you want to go through with a pregnancy or not. And for advanced maternal age, the risks are slight, I would say. It really gets into the big concerning ones when you have really bad heart defects, where someone was born maybe with a really concerning maternal heart defect, and a pregnancy would increase their risk of possible death, by 40%. That's a big risk to go through or take. And I spoke about, I have a non-ischemic cardiomyopathy. I've never been pregnant, never had kids. That was a choice because man, oh man, my risk would be very, very high of getting a cardiomyopathy again. And, medications that you have to take lifelong for certain types of things, et cetera. It was a risk that it just didn't make sense for me and my cardiac function. And I always share that with patients when I talk to them whenever they're trying to make decisions. It's a hard decision to make. However, it's your decision to make.
And you may not know the exact answer to this question, but before someone decides to do IVF, do they do a preconception meeting with like preconception? What does it look like? You mentioned somebody was not aware that these things might happen.
Yeah. So most of the time when someone goes through IVF, the reproductive endocrinologist will request a consultation, kind of like a preconception consultation before they proceed with IVF. And that can be done, it's usually done with an MFM. It's really the person who's perfectly made for that. I don't think OBs really do that as much as MFMs do. The thing that I found interesting is that some reproductive endocrinology offices and groups will require that. It makes sense, right? You need to understand the risks associated with IVF after you've become pregnant. Some of the reproductive endocrinology offices that are performing IVF put that on the patient. Hey, okay, we're going to schedule your transfer. We've got everything ready. However, you got to see MFM first and get a preconception visit. Those can take, it's certain private practice offices or bigger groups, it may take 6 months to get in for a preconception visit because they have a lot of high risk patients. And so they're seeing the pregnant patients. I had someone contact me through my website where I do the private consults. And she said she found me through Google, which I thought was crazy. I was like, I didn't know that. You could find me on Google for that. But this was the scenario that she had. And we got her scheduled. I do nights and weekends for those consults too, because people work and have families. It's very difficult to go to a doctor in the middle of the day. That's not good with your schedule sometimes. So we did a consultation within 48 hours of when she requested and got us all the records, et cetera. And she was able to proceed with her transfer without a hiccup whatsoever. So yeah, you'd think that it would be organized through the REI group. However, oftentimes it's not, but yet they require it. So that should be done for everybody. And when I say that, when I talk to people after they've become pregnant with IVF and they didn't know the risks, I guarantee you I wasn't the one that did their preconception consultation. I mean,
Well,
it should be talked about. Yeah.
yeah, you also mentioned that people can't hear everything you say. So maybe their doctor did give the information, but they weren't able to take it in at the
True.
time. But in those preconception appointments, do you also talk about the fetal risks of IVF?
I
Do
do.
you do that, or is that on the IVF team?
I do. Yeah. And my assumption is that the IVF physicians, right, the reproductive endocrinologist, more talk to them about the procedure, the hormones they're giving them, the risks of the actual procedure for IVF, and not much about what to expect after. Because usually when I do talk to them for these preconception visits before they've had their transfer, a lot of them are like, I had no idea that the heart defects are slightly higher after IVF. I had no idea I could have an increased risk of a placenta previa because of this. So, but you're right. It's hard to know if when I see people at 20 weeks and tell them they have a previa and they need an echo because of IVF, and they're like, I didn't know that. Were they told that and didn't really absorb the information, or was it not relayed to them? And that's a good question. It's hard to know that.
Probably some of each, right?
Yeah.
So if somebody's coming to you for a preconception meeting and they are advanced maternal age, are you asking them to be really healthy or take certain supplements, or is there anything they can do to build up their body to be able to maintain a pregnancy?
Yeah. So my general thing with preconception for advanced maternal age or not, in general, definitely a nice healthy diet. Higher in protein for sure. And I always tell people as best you can, chicken, fish, nuts, eggs. Those are our basic higher protein things if you think about it, lower in the simple carbohydrates. And then for any of the complex carbohydrates, we want to make sure to keep them brown and not white. So we want to get the fiber in there. I like to play a numbers game because with the apps and things like that, people are able to really keep track of things a little bit easier now than they could 10, 15 years ago. So my goal for people is at least 60 grams of protein per day, and 80 would be even better. Also 25 grams of fiber per day. So those are my big things that I like to encourage. And then as far as looking at carbohydrates, diabetic style diet is fantastic for everybody. So the best way that I talk about a diabetic style diet is breakfast should not be more than 30 grams of carbohydrates, lunch 45, dinner 45, snacks 15. That's like an easy way for me to remember it. So those are
Pretty
my
easy.
it's pretty easy, right? So those are my little rules of thumb, if you will, and stay well hydrated throughout. Regarding vitamins and things like that, prenatal vitamin for sure needs to be taken, should be taken for 3 months prior to becoming pregnant if you're planning this, right? And ensuring that the prenatal vitamin has enough folic acid. And I did a whole YouTube on folic acid too, because it's a big common question, and a whole YouTube on picking a prenatal vitamin. I legit went to ACOG, found their recommendations, put it into a nice table, referenced ACOG, of course, right? Put it in like pretty pictures and stuff. Because if you go to the grocery store and you're trying to find just even a multivitamin, much less a prenatal vitamin, so many to choose from, and you turn on the back and you can't read them because the ingredients are so small, and then the amounts, some are in micrograms, some are milligrams, and all this kind of stuff. And then it's just so much. So I put it all on a sheet where you can read to take it to a store and be like, these are the things that I need to have in my prenatal vitamin. Do I need an extra folic acid or not? So making sure it has enough of the folic acid in there. So the prenatal vitamin would be 1, folic acid would be 2. It may be in the prenatal vitamin, it may not. And then number 3 would be a low dose iron tablet for everybody. And that it takes a while for your iron stores to build up if you're doing oral iron. So I think it's great to start that 1 to 3 months prior as well. And if you're a candidate for aspirin, which almost all people who are advanced maternal age and have had use of IVF, if they have both of those together, they're a candidate. We like that to start sometime from 12 to 16 weeks in a pregnancy. So that wouldn't have to be started early necessarily.
Now, I know that we're not here to talk about this, but the difference between folic acid and folate and how it works in the body, we should
Yeah.
probably talk about that at some
Yeah.
point.
And we can do a whole separate thing on that one day if you want.
Yeah.
There's a great article that the CDC put out a couple of years ago that talked about all of the data and research regarding this. But the main thing I like people to understand is folate is the natural folate that you eat in your diet. Folic acid is the tablet you would take as a supplement, and folic acid is what is fortified in foods or put into foods that don't have folate. So there are certain vegetables that are high in folate, let's say. If you have a bread, pasta, or rice, that is fortified with folic acid. And the US did this years ago, and some countries have done this and some haven't. So you'll see folate deficiencies in other countries because some countries don't have wheats and grains that are fortified with this folic acid. And so that's where they noticed we didn't have as much of a folate deficiency by adding this into certain products that truly don't have natural folate in them.
So, in the collaborative part of advanced maternal age family coming to you, you can still continue to have that holistic care team, an MFM with an OB or maybe a midwife. How does that work?
Yeah, none of just being advanced maternal age requires you to be delivered by a maternal fetal medicine specialist. And again, you may never have a consultation with them as long as your OB is comfortable understanding and counseling you regarding those risks and making sure they have the right place for you to get that anatomy ultrasound. So I've known and cared for plenty of patients and co-managed them with various people at different levels of being an OB provider where patients have delivered with their nurse midwife. They don't necessarily have to deliver with an OB/GYN solely from having advanced maternal age. So they can continue care with their chosen provider for that. It's definitely nothing that would necessarily require having to regularly see an MFM unless in your community, the individuals that care for lower risk pregnancies are not comfortable managing someone that is of advanced maternal age.
Okay, then they might move it up.
Yeah.
So, but other people, like you had mentioned in our last talk, mental health providers and maybe registered dietitians, or maybe a childbirth educator or a doula, birth and postpartum doula might be um, part of that holistic care team. Are you getting into talking about that, or do they find those on their own?
It depends on the community I'm in all honesty. Some places that I work when I'm doing work in certain specific contracted areas, they have diabetic educators and just nutritional educators there in the practice, which is great. Some of them have mental health providers at the ready as well. I would say for doulas, those are a little bit harder to find depending on what state you're in. Um, and a lot of times patients reach out to them directly because they really want a good fit. Every doula is different.
So, when we're talking about advanced maternal age, you already mentioned more frequent ultrasounds. Are there other tests that you're doing? You said an echocardiogram. Is there anything else around making sure mom and baby are safe?
So the echocardiogram would be for IVF. So is not required or necessarily recommended for advanced maternal age.
Okay, thanks for
So
that.
yeah. So for advanced maternal age, particularly an early ultrasound, just to make sure to do any extra screening with regard to early ultrasound markers that we could see that would be associated with chromosomal issues. So there's kind of a new, and this is new in the last couple of months, where insurance will now approve a detailed anatomy ultrasound in the first trimester and then in the second trimester for people who are high enough risk. And advanced maternal age falls on that list. So I do think that in the next 5 to 10 years at least, we will start seeing more first trimester ultrasounds since they are approved by insurance. And I will say this, if you pick it up in the first trimester ultrasound, it is a legit finding, right? Like it is concerning because the fetus is so small. So we can pick up big bad things early on. And that's the beautiful part about an early ultrasound. So early ultrasound and the offer the blood test for Down syndrome screening. So that's the legit big thing. Then that big ultrasound, growth ultrasound or ultrasounds, depending, and then the antenatal testing. Those are the main things. And talking about aspirin if they have other comorbidities as well. And I mean, that's like the standard stuff right there. Yeah. And they, ultrasounds, I can't imagine anything extra than the ones that I just mentioned if it's solely just for advanced maternal age.
Okay. So thanks for reiterating that and kind of
Yeah.
bringing it all back together. Appreciate that.
Yeah.
So, when we're talking about emotional wellness, we talked a little bit about mental health, but how can we address even, besides sending people to mental health practitioners, how can we address fear and anxiety, and how can we help make things not feel so drastic?
Yeah. I would always start with opening the conversation of trying to understand what is it that's bringing about the fear for that person because it's different for everybody. So if it's seeing all the certain things on Instagram, if it's because you're at home with four other kids and you're pregnant now and you're scared of what's going to happen about having the fifth kid, what is it that's bringing, if you can identify it, right? What is it that brings about the extra fear or the extra anxiety? And then that would help us address it from a provider standpoint. And if we're at the point where we can't identify what's bringing about the fear, that would be the time where I would say this is a time for a mental health provider to really just help you. And it doesn't have to be a psychiatrist, maybe a psychologist, a therapist, a counselor, someone really to talk to see if you can kind of get to the point of understanding what is it that's bringing this about. Identifying it is a really nice way to be able to move forward and get through it as opposed to going around it. Because if you go around it, it may still be there when you come back, you know?
Exactly. Exactly. So, when the mom is preparing for labor and delivery, is there anything different that she has to think about than a mom who's 25?
I would say not necessarily to have to think about, but being aware that the risk of cesarean is higher. And that's something that's just a fact from the data, in all honesty. And that knowing too that if a cesarean happens, that doesn't mean that it is a failed birth. And if that's
Hmm.
something that is really important to someone to have a vaginal birth, just knowing, hey, baseline, this is going to be a higher risk, just slightly higher, but still a higher risk for you. So if this birth ends up being a cesarean birth and not a vaginal birth, you going to be okay with that? Like, let's wrap our heads around that as a possibility, so that when it happens again, we're not having to deal with any surprises there. So that would be one thing. Could the labor take a little longer, particularly if it's the first delivery for this person? It could. So those are the things I think just to be aware of. And again, that risk of preeclampsia is higher. And preeclampsia doesn't just happen in a pregnancy, it can happen postpartum as well. So,
Right.
those
Mhm.
are the things that I would be very aware of. And I mean, man, oh man, the blood pressure creeping up postpartum when you're tired and you're probably swollen and you just don't want to have to deal with one more thing is something to just be very cautious about. So if you had no blood pressure issues, be aware that that's a risk postpartum. So if you have headaches, extra swelling, particularly in your hands or your face, pain in your right upper quadrant, or like an epigastric pain, like underneath the chest and breastbone there. Um, Again, the headaches and blurred vision are the big things. Check your blood pressure. And if it's high, you got to get that checked out and go back into your doctor because that could be preeclampsia.
So I would say finding the right doctor I guess you keep saying depends on where you are.
Mhm.
Finding the right doctor may start with the OB or the midwife and then may move on to you as needed. Am I saying that correctly?
Yeah, that's it. Almost always starts with the OB provider, whomever that may be, that the patient has chosen as their OB provider. And depending on where they send you, if they send you out for any of those things, that may happen. And again, if an OB provider in their group does not send you to an MFM at all, someone needs to counsel you on your risks and whomever that may be, and figure out where you're having that big detailed anatomy ultrasound. Because if it's in that OB office there, inquire who's reading it and how they were like, how do you feel like you were trained enough to read it? And I will be very straightforward. I mean, and I said this earlier, I did not get that kind of training in OBGYN. That is not part of the basic training of OBGYN. It's how to baby's head down, I can check the fluid, I can do that biophysical profile. That's about it.
Hmm.
I mean, we,
Hmm.
we don't get trained in radiology or necessarily performing or reading ultrasounds as an OBGYN on a
But
routine basis.
a radiologist or an MFM or a specialist in reading those is what we're looking for.
And I am biased for this for sure, but I will say an MFM is the better one because I mean, I can't tell you that. I mean, there's something about the training of doing something over and over and over and over again, right? You get it, but
Specialized.
you
Hmm.
you
Yeah.
just it's a second nature thing. And sometimes when I'm reading ultrasounds, we've received a referral from a radiologist that read a scan and called something abnormal, which is actually normal. And man, that just stinks for that patient to go through 1 or 2 weeks to wait to get to an MFM, thinking that something is concerning with the fetus when everything is normal. So again, I don't know all the places where radiologists are reading these detailed fetal anatomy ultrasounds. However, I'm assuming that a lot of them are in smaller communities where they don't have an MFM. And so
Hmm.
that's who the OB is told to contract with, and that's how they have to do it. And then poor radiologist. I don't know any radiologist who goes into radiology going, I want to read fetal ultrasound.
Yeah.
They're probably like, I want to look at gallbladders and brains and bones and stuff, but I really don't like fetus is not in their natural wheelhouse, I would say.
Yeah, not their specialty. So,
No,
yeah. No.
no.
All right. So you had mentioned before if someone is sending you for an ultrasound without someone qualified, that would be a red flag, right?
Yeah.
If somebody says, and you had mentioned that somebody mentioned to you that they never heard those risks before. So maybe they were rushed out of a discussion or the doctor only had 5 minutes to spend with them that day. Um, that should be a red flag too. Are there other red flags?
I mean, man, there's probably so many. Anything that makes you feel uncomfortable to me is always a red flag. My other big red flag is if you can't reach anyone. And one of my big things on my 13 questions that you need to know to ask your OB provider, like the basic things for everybody, how do I reach you? And not just daytime, nighttime. So knowing and understanding that, that is a big red flag to me. If you call your provider's office and you can't reach anyone, or you call after hours and no one answers, right? Like you got to have someone to call. That's a big red flag. And then also, if you come in with questions and you get pushback because you're asking questions, right?
No
Like,
shared decision making. Yeah.
yeah, I mean, you really should be able to feel comfortable with that. And when you mention like feeling rushed and stuff, that one is so hard for me because I never want to feel rushed as a patient and I never want to rush someone as a provider. However, as a provider, I know that they keep stacking patients up for us all the time, and that's why I left the true private practice model I used to be in. But part of the reason is, you know, as the providers, and I always encourage patients to think about this for their provider. If they look rushed and they feel rushed, it's because they're rushed. Because after you, they have 17 more patients to see. It's probably not even the afternoon yet. And they started late because maybe the first patient had a really poor outcome and they spent extra time with them.
Mhm.
And it's a kind of like, the snowball effect of how the day can go south. And I do always, if I ever jump on a screen with a patient and I'm late, I try my best to apologize and let them know, sorry, we had something we had needed to deal with today with a poor outcome, or I'm sorry, something happened, just to let them know because their time is important.
Mhm.
So I do struggle with that because thankfully I don't feel rushed as much now as I used to feel in back in the day. And I do have a very soft spot for providers who are in a big system where they don't have any autonomy for themselves to move their schedule around. And it's like 40 patients is a typical day for a lot of doctors. And some of my 40 or 50 is very typical. Imagine having to spend or having to chart on all those patients and wanting to spend time with them but not being able to because you would be there until midnight. you know
Yeah.
it's a very it's not fun to balance, and I feel for a lot of the docs that are still in that space. It's a rough space to be in.
Yeah. And thanks for sharing that because it gives us a little bit more wisdom when we're thinking about that subject. Okay. So, can people who are just 35 to whatever, they can still have a birth plan and everything. They just probably need to make it more flexible. How do you feel about that?
Yeah, anybody coming in with a birth plan is always accepted, and because I know of people listening that will probably say, well, she's a doctor. So doctors don't usually say that. And I will say in residency and in fellowship, when people came in with like a 20-page birth plan, we always felt like it was a jinx for that person, right? Like the
Yeah.
more you come in with, the more like unfortunate events are going to happen, right? Like, and it was almost like if you're a provider and you're in the medical field and you become pregnant, it's like, oh well, you're going to get preeclampsia and you're going to have HELLP syndrome, and it's a jinx thing we talk about, right? So that was always kind of like the running thing was the more of a birth plan, the more stuff will go sideways just because of the randomness of the universe, kind of thing, right? But I wouldn't say that having low or high risk, number one, says you can't have a birth plan. Number two, for the flexibility, I think it's always great to have flexibility in whatever it is, because the goal for patient and the provider, in my strong opinion, is always to have healthy mom, healthy baby, right? Healthy and safe. And so however we can get there is great, and doing the best to take into account all the things that are part of someone's birth plan. And if it's something a little different, explaining to them why it's important and would they be amenable to it in the instance of blank. Like if this happens, would you pivot this way for safety for you and baby? And if that conversation's open, it's great. But if you get a provider who gets real aggressive, it just, I mean, man, oh man, there's no need for that.
I agree with that. And sometimes a parent doesn't understand um, why the provider is being aggressive, and maybe the provider doesn't understand why this is important to the parent. So I
Yeah.
think that good communication is the solution to that.
Yeah. And giving examples of things as to, like, if someone says, I refuse, and it's also the verbiage used, right? I refuse this, like for a birth plan, versus I would like not to have blank, right? So someone who, let's just make up an example, refuses to have an IV, right? Okay. Um, that's your choice. And if we get into the place where we need to have a cesarean, or you have a lot of nausea, vomiting, or the baby's heart rate goes down or whatever, we would have to then place the IV at that time to help possibly resuscitate or do certain things, which would be a very traumatic, trying to find someone to get. I hope so much that providers, when they speak to a patient, can have the communication skills to explain why a certain intervention may be warranted, so that there's a good communication. And a big part of it is communication. Fear is in there because part of the communication sometimes is so broken in our world that people don't know what to do with it,
I agree. Communication is key. All right. Well, we're getting close to the end of our time together. Any last moment thoughts on advanced maternal age for our listeners?
Advocate for yourself. Ask the right questions, in all honesty. And advanced maternal age, if you see it coded somewhere as elderly multigravida or elderly primigravida, which you'll see on your billing statements if you ever open up an insurance package, don't take that to heart. Somebody made that, up in the past and had that in there. Or geriatric pregnancy, that's another one that I've seen on the billing. It's really just there to counsel you appropriately and make sure that we can watch you and baby closer to make sure everybody is as safe and healthy as possible. So,
well, thanks again for your wisdom. Appreciate talking to you.
Anytime. Thank you so much.
This episode of InCast is complete. Tune in regularly to hear more insightful conversations. And be sure to visit enjoyhealtheducation.com to see how Enjoy can help you inspire families and staff through our diverse childbirth and parenting teaching solutions. Or call us at 1-800-326-2082. The views and opinions expressed in this podcast are those of the guests and do not necessarily reflect the official position of Enjoy or its employees. This podcast is intended for informational and educational purposes only and does not serve as medical advice, a basis for diagnosis, or recommendation of treatment.